Meeting will begin in a couple of minutes. All right, Tracy, I have 2 o'clock if you want to get us started.
Good afternoon. Thank you all for joining us today for our weekly update on COVID-19 across the Lake Cumberland District. We have some members of our executive team that will be sharing information and answering questions that you all provided over the past week. Sean, do you want to give us some updates before we start with the questions?
Sure, I can. And by the way, Tracy, you were sounding just a little garbled, so I don't know if you're close enough to your mic or not. So currently we have had 296 total cases in Adair County, 19 deaths, 262 released cases, leaving 15 active cases, 14 isolated, 1 in the hospital. 264 cases for Casey, 16 deceased, 246 released, leaving 2 active cases, both on self-isolation. So Casey has our least number of cases right now. 100 total cases for Clinton County, 2 deaths, 80 released, leaving 18 active, 17 isolated, 1 in the hospital. 95 total cases for Cumberland, 0 deaths, 91 released, 4 remain active, all on home isolation or self-isolation. 248 total cases in Green, 9 deaths, 203 released, leaving 36 active cases, 32 isolated, 4 in the hospital. 132 cases in Macquarie County, 0 deaths, 117 released, leaving 15 active, 14 of those isolated and 1 in the hospital. 710 total cases in Pulaski, 9 deceased, 611 released, leaving 90 active, 87 of those on home isolation and 3 in the hospital. We've had 240 cases in Russell County, 6 deaths, 198 released, leaving 36 active cases, 35 of those isolated, 1 in the hospital. 270 total cases in Taylor with 6 deaths, 215 released, leaving 49 active cases, 47 of those are isolated, 2 in the hospital. 122 total cases in Wayne with 0 deaths, 107 released, leaving 15 active, 14 of those isolated, 1 in the hospital, for a district total of 2,477 total cases, 67 deaths, 2,130 released, leaving 280 active cases, 266 of those isolated, and 14 released. We will be adding to our total cases today 3 new cases for Adair, 3 in Cumberland, 2 in Green, 2 in Macquarie, 5 in Pulaski, 2 in Russell, and 4 in Taylor. And the 2 in Macquarie is tied to the prison down there. I know we get questions often about how many cases they've had in the federal prison. So they do have 2 cases there. That does get reported to us, even though we don't have a lot to do with their response. Being a federal prison, they usually deal with that internally, but the cases do get reported to us. Interesting things that have happened this week. I guess the two most interesting things on our end is the change in the definition of essential workers and the release of the school metrics to determine guidance when schools should be in-person session and when they should not. As far as essential workers go, the definition has been restricted. An essential worker now is defined as basically a healthcare worker or a first responder, and then only in a situation where it is absolutely critical they be there. They can't operate without them. I'm talking about if you are a contact, not a case. All cases, of course, are isolated, but if you are a contact, you could still work if you're an essential worker, which now is only healthcare workers and first responders, and only in critical situations where they can't operate without them. Why did the guidance become more strict? Stuart and I spent a little time talking about that this morning. The whole definition of essential workers, that came out at a time when Kentucky was, having the economic shutdown or the lockdown or the healthy at home, whatever you want to call it. And, the essential workers were defined so that while everyone was staying home, who absolutely needed to be working in order to keep like food and utilities and medical going. So the category was a little broader then. Of course, when everyone was being healthy at home, there was less concern about community spread because most people were staying at home. If you were going to have a cluster, it would have been at one of these facilities, and maybe the workers at those facilities that were allowed to stay open, might go back home. But now that we're no longer healthy at home, since we've been allowed to transition to this healthy at work model where, most things are open at least to some degree, people aren't staying home all the time now. You have people out and about going to more places. So you have to be more concerned about community spread. So, there's more concern now if you're a high-risk contact, since the potential for community spread is greater. It's the safest thing to do for them to quarantine at home and to try to prevent increased community spread where people aren't staying. I hope I'm explaining that in a clear way. Stuart, can you re-say what I said in a way that can make it clearer?
I mean, I guess what we want to try to say is exactly what Sean was saying, but now that things are open and we're not doing the healthy at home anymore, and people go to work and they maybe they're exposed somewhere and they should be quarantined. Well, now those people, and the people around them, like their family that they come back to, those people are going out and they're going possibly to the movies, and maybe their kids are going to school, and maybe their kids play sports and they're going to church, things like that. So we know that these people that are quarantined, they have a higher likelihood of becoming positive because now they've been exposed to a case. Used to, we would let them go to work and do a restricted quarantine where they come home, and the only people, if they were healthy at home after that, would be to possibly expose their family. But since now things are open back up, then their family's able to get out. And if we knew, you can't test out of a quarantine. So what I mean by that is if you're quarantined for 14 days, you have the possibility to become symptomatic and to become a case anytime in those 14 days. Well, if I test on day 1 or day 2 or day 5 and I'm negative, that doesn't mean that I'm not going to become positive on day 6, 7, 8. And if we were able to know that, and this is something else that me and Sean talked about this morning, if we were able to know everybody who had it, and every asymptomatic case out there, well, we would we could have wiped this thing out, you know, a long time ago, but we're not able to know that.
Yeah, because there's asymptomatic community spread, we can't know everyone who's positive and spreading it. If we did know them all, we would isolate them all and it would burn itself out. That's the point. You would isolate the cases, you'd quarantine the close contacts, and it would burn itself out. But we don't know everyone who has it, obviously, because it's still spreading freely in our communities. Even if you back out nursing home clusters, we've still been running anywhere from 25, 35, 40 cases a week for several weeks now. So it's still spreading pretty freely in the community. So anyway, the whole thing about restricting essential workers is the recognition that there's a greater potential for much broader spread in the community now that people are out and about. Now, you may agree with that, you may disagree with that. We don't set those rules. I'm just sharing with you the logic behind why the rules changed. The other significant thing that happened this week was the release of the school metrics. You know, from a public health perspective, making county to county decisions during a pandemic, you know, it's not the best public health approach because, you know, people leave our counties every day to work in the neighboring counties or to travel, and people travel into our counties every day. So, you know, the disease is going to spread across county boundaries, but you know, our communities were demanding a local decision-making metrics, and the governor's office produced that. So now, in a nutshell, this should be into in-person instruction and be allowing extracurricular activities like band or sports or cheerleading or whatever, any kind of extracurricular event or practices. So the metrics is if you're having a 7-day average of 25 or more cases per day per 100,000 population, that your county would be considered in the red critical area. And at that point, the community information is telling you it's not a good idea to be having those things going on. Now, people, I get questions all the time about this 100,000 issue. They'll say, well, you know, there's not 100,000 people in my county. How are you calculating that? Well, let's say your county has a population of 10,000. 10,000 is 10 times smaller than 100,000. So if you have one case, for the statistical reasons, you would multiply that by 10. So you'd have 10 per 100,000 or 1 per 10,000. It's the same ratio, however you say it, but most of the time statistically, when you read professional articles and so forth, it's always standardized to be as a measure of per 100,000. They do that so you can compare counties to counties. 3 cases in a county with a population of 6,000 is way more cases than 3 cases in a county with a population of 1 million, like Louisville. I mean, Louisville, that would be almost like nothing, and in Cumberland County, that would be a tremendous amount of cases. So you have to standardize it so you can compare it. So anyway, if you're having more than 25 cases per 100,000, that's considered red critical spread. And then it would be recommended that all in-person instruction, extracurricular activities cease until the county is back down into the yellow zone. So there's 4 zones: green, yellow, orange, and red. In the yellow zone, it would be 10 or under per 10,000 would be that. And you might say, well, why do you have to drop all the way back down to yellow? The logic is in some of these small counties, when if you have a bad day, you can jump from being a county in the yellow to being a county in the red. And then the next day you might not have any cases and you would drop it again. So, I mean, where you have small populations, those can change very quickly. So, going from red back to yellow was kind of the compromise. The other question we get about that is, well, who makes the decision then to shut those things down? It is not the health department that makes that decision. it's current law that the school board and the superintendents are the ones who decide whether or not a school opens or closes. They make that decision when there's snow. They make that decision when there's flu, or for other reasons. They set the school calendar and decide when to open or close. Could the health department shut down a school if we thought the situation was bad enough? Not really on our own authority. We couldn't. We'd have to go to a judge and get a court order for that to happen. So certainly with COVID-19, that's not going to be something we're going to be rushing to the court every time a county goes into the red. We believe that the superintendents and the school boards are well-educated people that can look at the information and make an educated decision. If you're a parent and you don't agree with what your school is doing, I'm telling you that to say it wouldn't benefit you to reach out to the health department. We don't make that decision. You would be better served to reach out to the school boards. And I'm not saying that to be mean. I mean, the schools are trying really hard to create a safe environment, and they're in a very difficult situation. They've got parents that don't want school going on, and they've got parents that do want school going on, and they've got school board members who want school to be in session, and school board members that want things to be closed. And I mean, they're in a vice, just like public health is with this. And it's a difficult situation for them. But anyway, if you aren't liking what the school is doing, you would be better served to direct your complaint to the school and not to the health department, because that's not our decision. So anyway, that's the two big changes. Anything to add on school metrics, Stuart or Dr. Lehman?
I just to make it really easy, what Sean was saying there, when we use the 100,000 because that's what the state's using, that's what the nation seems to be using. So 25 average, 7-day average on that. So what that means, to make it easy for a county with 10,000 people, it's 2.5 cases. So the smaller your population, the way smaller the number has to be that you're averaging over those 7 days. And then also I did want to make the point, I have our call center today. They've asked us when we do get these school complaints, and it is like Sean said, please refer them to the superintendent of the school. They are they're the person who's over the school, and then they can relay those complaints back to the school board or wherever they need to be relayed to. And I did speak to the superintendent today, and he actually told me, I mean, if there are complaints in his school district, I mean, he does want to know about those. So I think if you have an issue that you're not sure about, that you are that you question in your mind, especially when all these kids get back to school and your kids get back in school, reach out to those people, and I think they'd be happy to talk to the parents that have children in their schools.
If you want to know where your county is at any given moment, the information is available on the state website and on our website. If you go to our main COVID-19 page, you scroll about partway down, it'll say 7-day incidence rate, which is just what your average number of new cases in the last 7 days. And we've already got the counties color-coded on that map, so you can know if are you presently red, green, yellow, or orange. And then on the state's website, the Kentucky COVID-19, you can download the little, there's a one-pager there that shows what actions are recommended for the schools at a level red and what actions are recommended at an orange. So really all you gotta do is look at your county color and then look at that sheet and see what the recommendations are. So tried to make that as easy as possible, the folks who put that together.
And I think one thing they said was that the superintendent should check that on Thursday evenings so they can make that decision then for the following week. So if a county does turn red, mid to end of the week, that decision then would probably lag over into that next week to make that call to cancel school. The other thing, and I don't know that you said anything about it, the new change where schools are required to report cases and parents are required to report illnesses.
Yeah, that's part of the metrics that it's at least related to it that they discussed too. So you are right. Parents are required to report to the school if, the child is positive or if the child is a contact of a positive, so the school can keep up with that. What we don't want is we don't want anyone that's in a risky situation to be coming to school. So, the school needs to be aware. So, if a child shows up for whatever reason and they're a positive case or a high risk close contact, the schools can stop them before they get into the building. So, we want the schools to be successful. And, we have schools in our district that have been open for a while. Some of them have had to close back down and some of them have not. So, it at least in the short term can be done successfully. We're seeing it happen. So we want to give the schools as much of a chance as possible to be successful. Now, I say that the schools are running successfully, that means that they haven't had so many positive cases related, to the kids or the faculty that are going to that school they felt a need to close. We don't know exactly, but the tricky thing about the schools is kids are the most likely to be asymptomatic. And if you have children who have COVID-19 who aren't showing symptoms, you may never realize they're there, and they may infect several other students and teachers while they're there. And since the kids are least likely to show symptoms, you may never see it in the school, but you might see it 3 weeks later in the community when the kids bring it home to mom and dad or grandma and grandpa, and mom and dad and grandma and grandpa take it to work and church, and you start seeing this increase in the community spread. So if there's going to be an impact to all of this, additional activity happening in the communities with sports and school, we're going to see it, 3 or 4 weeks later. So hopefully, we're just as hopeful as anyone that we don't see any kind of increase based on any kind of school activity. But if you're going to see it, that's probably when you're going to see it. Tracy, if you're talking, you're muted.
Sorry. Thank you, Sean. I do want to remind everyone that if you have questions, please put those in the chat box and we'll get to those as we walk through the meeting today. First question, out of the long-term care centers district-wide that have had outbreaks, what percentage of the total number of residents tested are positive?
Yeah, and I 2 or 3 of us this morning tried to think of a way to answer this question and to come up with some data, but that's just not something that we keep up with. We have clusters or outbreaks at all types of facilities, not just long-term care, in jails, in factories, in medical facilities, in the health department. It's not something we keep up with how many, what percent of the people who work at a particular location, or what percentage of people who are present at a particular church, or what percentage of the staff at a long-term care. That's just not something we keep up with. We respond to every case. And when a facility has, when there's a cluster, when there's more than one case in any location, we respond to that. We don't wait until you reach a certain percentage to respond. So, there's never been a need for us to keep up with that information as part of our response. So we just haven't. So I really have no way of answering that question. So I'm sorry, but we just don't have that information.
Okay, thank you. Next question. Governor Beshear said Monday he believes it's time for health departments to issue citations and fines for non-compliant businesses. Has a local district been doing this, or do we plan to do this?
Let me make 3 or 4 points here on this question. the first point I want to make is that our complaints over the past few weeks have definitely been going down. I mean, we do still have our line that you can call into the health department, or where you can go online and make a complaint. But for our district, our complaints has really went down. Actually, just a funny side note, a lot more complaints in other states that people accidentally send us than we see complaints that are in our district at all. So I want to say that. Let me say this also, that you have to remember that the health department has been advised that the only places that we are tasked with any type of compliance is businesses that we normally inspect and permit. So what that is we don't inspect and permit hardware stores. We don't inspect and permit parts houses for car parts. We don't permit and inspect factories. So the large line share of businesses is something the health department really has no enforcement in. Those type of complaints would go to the Department of Labor. So the ones that we are the ones that we do have enforcement over and we're responsible for, those seem to be the ones that, for the most part, they're complying. We're talking about your food service places, your grocery stores, things like that, where the employees, are wearing their masks. We'll see that most of the customers that come through are wearing their masks, which brings me to another point. When we see a place and we talk to a place about masks, you can't just go into a store like a Kroger, a Super Kroger, or whatever they call the marketplace, Kroger, huge store. You can expect, if you see an employee that's got their mask down for a minute, I mean, of course, people, even everybody out there, that you pull that mask down every now and then. You have to catch a little bit of you just need a little bit of a breather there for a minute or two. And for the most part, we'll see the patrons in the store. Most of those people are masked. You're going to see a few people out there who are they refuse to do that. And if you tried to talk to these people, these people are going to bother. You're going to have a confrontation with those people. CDC recommends that they don't want employees having confrontations with some of these customers and get into a situation. We don't recommend that either. We don't want people getting into a situation where somebody gets hurt. So you have to remember that. But I do want to say that we've not had to issue fines yet, not to the places that we're responsible for. We still do get a few phone calls, but we've been able to reach out to these people, to educate these people, and to get compliance out of these people, or these businesses, these employees.
Our goal is not to punish a business. Our goal is to just get compliance. We're not trying to enforce compliance out of some power trip. It's all about, we just want to keep the spread of the disease as slow as we possibly can until a vaccine is available. And we may talk about that more in a minute. It was suggested that I show how we get the information on our website that we were talking about. So I'm going to try to share my screen here and show you that.
Sean, you're a little bit muffled, so you might want to repeat that again.
Are you seeing my screen when you're in?
Yes, sir.
The website? Okay. So it was suggested I show how you get to the information via our website. So if you go to our main homepage and you click this main COVID-19 banner, The information is on there's a whole lot of additional information on this page, other than the things that we share in our daily brief. And, this is all of the information for all the counties, trended by week. It shows new cases, total cases, deaths, hospitalizations, different things. So you can always go back and look at that. Demographics. But the part we were talking about today is whether a county's red, orange, yellow, or green. Now, we update our data every day. The state data will probably be a couple of days behind ours. So, we certainly encourage you to do what the governor said, look at the state site. You can be very confident that our data will be a day or two ahead of theirs, and their maps will change to match ours, a day or two later. So that's available. That shows, you can see schools has moved up to being our second most common things that cases are tied to, getting very close to being our number one thing. When I say schools, I mean that category is really school related. It can be kids in the school age group, and it can be faculty and staff, or it can be kids that are going to college. So there's a lot of things that fall into this school category. There's another place you can look. If you go down to the bottom of our accordion menu here and click this additional information, it'll take you straight to the Kentucky COVID-19 website, where they include a lot more information. This is testing sites, but if you go down, they have these maps too, and this one's the one I use each day to get the case count, state's case count. But there you'll see the same map once it loads that you see on our site as far as counties. So right now you see they've got two of our counties. They haven't highlighted Taylor yet. They may highlight it today after they update their numbers. So that's how that works. Tracy, was there anything else?
No, I think that's all. Thank you.
All right. Has my screen share stopped now?
It has.
Okay.
Next question. If I give blood and if it's positive for antibodies, will that be reported as a positive case regardless of whether the antibodies are a result of exposure or actually having the disease? And then there's a two-part to this question. Do you know if the Red Cross test can differentiate between the two?
Okay, so if you have antibodies to a virus or a disease, that means you've had the disease with or without symptoms. So those people that didn't know they were sick, they had absolutely no symptoms but still have antibodies, had been infected, they just were asymptomatic. So the way you differentiate is by asking the patient, have you had symptoms or have you not had symptoms? So the test doesn't tell you that. It's the history that tells you that. No, the Red Cross does not report either negative or positive tests. If you go to their website, they will discuss how you can find out your results by logging on. They also state that the testing is not diagnostic. And it may actually not confirm immunity to it. However, if it is a true positive, which sometimes is difficult to say because sometimes these tests can have false positives. However, on questioning, they will assess whether this is a true positive, and then you may be a candidate for donating plasma.
Dr. Raymond, that talking about antibody tests, that's a common question I get on social media or emailed to me is how can antibody testing, how can we add someone to our total cases and release them on the same day? And a lot of times it has to do with they went and got an antibody test just to determine if they've had COVID-19 at any given time. And maybe they think they had it back in April. and they just go get tested to see if they had it in April like they suspect they might have. And if it comes out positive, then yes, we would add them to our total count but they would never be added to our current count or our active count because they've already recovered. It would have been, if they would have tested back when they were active, they would have added to the active. So that's how they end up being released. Now, there is a very rare instance when somebody will be positive and they just delay going and getting the test, and then the lab might, for some reason, be a little behind, and the results might not come back as quick as we would like. So just very rarely there's a situation where by the time the person actually gets around to getting tested, and by the time the lab results get back, they're already recovered by the time we're notified of the case. But most of the time it's an antibody test when you see that situation on our website.
And to add to that, the antibodies don't become positive for about 10 to 14 days. So basically that person would already be out of isolation because it's been 10 or 14 days when their antibodies become positive.
Okay, thank you all. Next question. While I understand and appreciate the steps taken to protect nursing home patients, with no foreseeable end in sight for this disease, will there be a reevaluation of the restrictions anytime soon? And this is for the long-term care facilities, I'm assuming. It goes on to say the loneliness and depression that these patients are experiencing surely must have to weigh into the decision if this lingers on for months. And then it asks about, shouldn't there be more ways to allow social distancing or being masked or plexiglass visits or outdoor visitation?
So there are, as I understand the guidance right now, and Stuart or Dr. Wayman or Laura can correct me if I say this incorrectly, the guidance does allow for some visitation right now, even in nursing homes, providing that you haven't had an active case in your facility for 28 days, if you're a skilled nursing home. Now, if you're a personal care home, I think we determined that's 14 days. So going by whatever restrictions the facility has in place about how many people can come in and where you would meet at, and if you have to wear a mask and so forth, it is allowable. But now the facility management has the discretion to not allow it, even if it is allowable, even if they could allow it. Let's say they get into a place where they haven't had a case in 28 days, but they're not comfortable taking the risk of allowing visitors in because they just heard about a very large nursing home outbreak, in the neighboring county the day before, and they're just not willing to take that risk. I understand this is a double-sided sword. I had a family member who had someone close to them that had to go to the hospital. Now, this is not a nursing home, but it's something I can relate to personally. And, my family member wanted very much to go see this person, but they couldn't, it wasn't allowed. And, it was very emotionally challenging on everyone involved that you couldn't have that visit at a time when you really felt like you needed to have that visit. So, this is probably the most tragic double-edged sword that you can think about in the situation where, you have elderly parents in a nursing home or elderly family members or loved ones that, may not have many days left to live, and you can't go and spend time with them, and they don't understand, and they're lonely, and they long for that visitation, and you long for that visitation. So definitely, I understand where you're coming from. I also understand that we've had several, nursing home outbreaks in our district that's resulted in lots of cases, lots of hospitalizations, lots of mortality. And I can see the side of the administrator that's trying to avoid that. So I don't know. This is a really, really tough one, and I don't have an answer. I think you just got to try to talk with the nursing home administration, and if they're in the time frame where visitation could be allowed, to just try to work with them to work something out. I don't have a better answer than that. I don't know if anyone else in the room does.
Do know this too, that as a visitor, when that nursing home or personal care home is open for visitation, they are going to quiz you. They're going to give you a questionnaire that you have to fill out, and this questionnaire is a lot more in depth than the questionnaires that you may experience if you're trying to get into a football game, say, where they asked you if you've had any of these symptoms. That's going to be one of the questions, but they're going to go much more in depth. They're going to ask you if you've been around anybody positive. They're going to ask you if, while you're out, do you follow the guidance and do you wear the mask? So it's very important if you are going to go into a long-term care facility to visit someone, which of course, I mean, again, like Sean said, I mean, my grandparents were in a long-term care facility, and of course, my mom and dad wanted to visit them, and I wanted to visit them, and we did. So it'd be terribly hard if you couldn't.
Yeah, but it wasn't during COVID.
Right, I did, and it wasn't during COVID, so I know it'd be terribly hard if you couldn't. But, you know, if you're going to go in and visit, remember, there's a whole lot of other people in that nursing home too. They have to make sure that you as a visitor, you know, that you're not going to be the person to bring that in. And I mean, I know we all think that, well, that wouldn't be me, but the way COVID works is sometimes it is you, whether you mean to or not. So I say all that to say this, you know, if you have a loved one in a nursing home and you want to visit those people, please make sure that you are following all protocols when you're out living your life away from that visitation, so that when you do go in to see the person that you want to see, that you don't accidentally bring something into that facility that can absolutely devastate a facility and can, as we've seen, can kill a lot of the people there, a lot of the residents.
By the way, this is off the topic, but I was asked to announce that we will be having a special called Board of Health meeting for Casey County on September the 22nd at noon. It'll be via Zoom. It'll be on our YouTube live channel. It's to discuss they've purchased a new building and they're remodeling it. It's kind of just a business meeting about that. But if you're interested in that sort of thing, that'll happen September the 20th at noon you can watch it on our YouTube live channel. Laura, was you going to do a presentation?
Mm-hmm.
Okay. Is that tied back to a question Tracy's getting ready to ask, or is that something different?
I'm going to actually preface it for you right now, Laura. Evidently, there's been
Okay.
lots of questions about contact tracing and case investigation. So Laura's going to do a presentation for us. Laura, I'm going to switch that over. Hold on just a second, okay?
Okay.
And you may have some more you want to share as I'm pulling.
No, we get several questions about contact tracing, and people just seeking to understand more about that and how that works, and some of the terms that we so very often use, and we just want to take an opportunity to offer some offer some information on that and answer questions if there are. So the first thing to talk about is what is a confirmed case of COVID-19. So that's the first slide. Are you able to switch those, Tracy, or will I need to try to do that?
I will. Can you see it, Laura? Are you seeing anything now?
I
don't think you are. Okay.
Yes.
You can see it?
Yes.
Okay, I can change it for you.
Okay. So the first thing is a confirmed case of. Do you all see her? Do you see the whole thing?
Yes.
Okay. Okay. It's what a positive lab of COVID-19 is a what we call a PCR test. It's a molecular amplified detection test, or a detection of an antigen. Both of those specimens are nasopharyngeal or nasal specimens, so those are collected by a swab in the nose. So if anyone's ever had a test, they're familiar with that. Another way that COVID is diagnosed is as a probable case. That's the next slide, Tracy. And a probable case meets clinical criteria, and that person has also been in contact with somebody that's a positive COVID case. Or they have positive antibodies, which I think Dr. Wayman spoke about earlier, about what an antibody for the disease is. These cases in our, as of today, 2,477 cases, the probable cases account for about 3.7 of the total of our cases. So those are very, very few. Most of
3.7%.
3.7%, yes. So that other percentage is all lab confirmed cases. Next slide. So we'll talk about the terminology that we use when we do contact tracing. The first thing that we'll talk about is what is a contact. So the Kentucky defines a contact, the Department of Public Health.
Next slide, Tracy, please.
Is a little stricter than the CDC. I don't know if strict is the right word to use, maybe a little more specific. A contact is someone that has had close contact with a confirmed probable case of COVID. These persons are within 6 feet for more than 15 minutes with or without a mask. And that is the 15 minutes cumulative time. So maybe you work with someone and you've not been with them at 15 minutes, you've not been in that space 15 minutes all at once, but maybe a couple of different times during the day you were in that space and that equaled more than 15 minutes. Then you would be considered a contact also. Next slide, please. And a contact also, there's different situations that have to be assessed by our contact tracers when they call contacts. Maybe someone coughed or sneezed upon you, so then you would be a contact. Maybe you're a roommate sometimes at college. They're not within 6 feet of each other, but they're a roommate and they've slept in the same room. So then you would be considered a contact. Sharing food, drink, hugging, kissing, or unlimited enclosed space with limited ventilation would make you be considered as a contact also. So sometimes we get pushback on people being contacts because they say, well, I had a mask on. Well, CDC and Kentucky Department of Public Health say that mask does help to reduce the transmission of the disease, but it doesn't change the recommendation for quarantine. So we may reach out to you, we may ask if you've had a mask on, but if you meet the other criteria as I talked about for being a contact, you will be still asked to quarantine very likely.
Because it reduces the risk. It's a prevention measure that
Right.
reduces the risk, but it doesn't eliminate the risk.
Exactly.
So if we know you've been in close contact with someone who's positive, and if we know that a mask doesn't totally eliminate the risk, you would still be a contact. That's the logic.
Yes. So if you are a positive case of COVID-19, we ask you to isolate yourself. And what that means is when someone is isolated, you separate sick people with people who are not sick, because for obvious reasons, we want the people who are not sick to remain well. Quarantine separates people who have been exposed to the disease to see if they become sick, and also to control the spread. If people that we ask to quarantine should stay home, they should separate themselves from others, be aware of their health symptoms, and just follow the general directions given to them by the local health department. Generally, a quarantine is 14 days past the exposure of the disease. Next slide. Contact tracing is not a new, it's not a new idea. It's something we've been doing for decades by local and state public health. And contact tracing is to stop or slow the disease, stop or spread the incidence of the disease. How that works is by letting people know they have been exposed, by educating them on signs and symptoms. We ask people to self-isolate or self-quarantine depending on whether they're a case or a contact, to keep them away from others during their infectious time or potentially infectious time. During contact tracing, we saw a lot of scam. We've got questions. We'll never, none of our tracing staff will ever ask for money, social security number, any personal information like that. It's general demographic information is what we ask for. So what you can expect if you have been diagnosed with COVID-19, you'll get a phone call from the health department. A contact tracer at the health department will give you a call. They're going to ask you some things about your symptoms. They're going to ask you to self-isolate and give you instructions on what that means. And then they will ask you who you've been in contact with 2 days prior to your symptoms. And we'll need some contact information on those folks also. Next slide. So once we get the information on the contacts, we reach out to those folks and ask them to quarantine themselves for 14 days past the exposure from the positive case. It means self-quarantine means to monitor your health symptoms, stay at home, maintain a distance from the others in your home if they aren't quarantined themselves. The health department staff just does a lot of education. We ask you to take your temperature twice a day and just watch for symptoms. If you were to develop symptoms while you're quarantined, we recommend you reach out to your healthcare provider and get a test for COVID-19. Next slide. So here's just some scenarios about quarantine. This person says, I've had close contact with someone who has COVID and will not have any further interaction with that person while they're sick. So the day of the time period they would quarantine would be 14 days past their last interaction. Okay. The second scenario, this person says, I live with someone who has COVID and that person has isolated themselves in a separate bedroom. I have no close contact with that person. So when that person isolated, you can count 14 days and then the quarantine would be up for the contact. Next slide. I live with someone who has COVID-19 and started my 14-day quarantine period because we had close contact. What if I ended up having close contact with the person who is sick during my quarantine? What if another household member gets sick with COVID-19? Do I need to restart my quarantine? Yes. You'll have to restart your quarantine from the last day you had close contact with anyone in the house that has COVID-19. And then the last scenario, I live in a household where I cannot avoid close contact with the person who has COVID-19, and I'm providing direct care to the person. I don't have a separate bedroom to isolate. or I live in close quarters where I'm unable to keep a distance. So in this scenario, with continual and repeated contact, the person should avoid contact with others outside the home while the person's sick and quarantined for 14 days after the case has been released from home isolation. So many times that's up to 24 days, it could be. Okay. Here's some questions that we have received. This is regarding students in the school system. If a student or staff is a close contact, maybe in the same household with someone with positive for COVID, will they automatically be quarantined? And yeah, the answer to that is yes. If I am a close contact, even wearing a mask, do I have to quarantine was the rest of the question, and yes, it is. We talked about that earlier, that masks are meant to protect other people in case you were infected, but not to protect you necessarily from being infected. So I think that's the end, and we'll take questions if there are questions, Tracy.
So the chat feature is open. If you want to add a question in, please do that. Our live broadcast here is about 20 seconds ahead of what's showing up on YouTube. So the only,
So a thought, Laura, here, and I have a question, is how often does the health department contact people during the 14 days? Do they contact them daily, or how does that work?
So for the contacts, we just reach out to them the first day we know about them and give them guidance. For cases, positive COVID cases, we call them daily until the end of their isolation period. Generally, an isolation period for someone that is normally healthy is around 10 days, as long as they are improving and have been fever-free for 24 hours.
Okay, thank you.
For a case. Now, if they've been hospitalized or they're long-term care resident or they're immunocompromised, then that time sometimes is longer. But the minimum that a case would be isolated would be 10 days.
Yeah. So while I got you and Dr. Wayman in the room, there was a very, I guess, disturbing complaint this week of trying to preserve confidentiality, a county person, someone in a significant position in the county who is a case, not a contact, but an active case, going out to a public place and feeling like it was okay to do that if they stayed a few feet away from everyone. Now, you all can probably answer this in a better way than me, and I will let you chime in, but just because you're a few feet away, 6 feet away from people and have a mask on, that guidance is for prevention. That's to help reduce the risk that you could catch it or spread it. Once you have it, 6 feet in a mask, that's no good for you. You're a positive case. You're to be isolated and separated from the public, period. 6 foot bubble's no good for you anymore with a mask on. No good. If you're a positive person and you're out in public and you sneeze or cough, you have infected people around you. So either that was just open defiance or a severe misunderstanding of the difference between prevention guidance versus, post-exposure restrictions. So I don't know if you all have anything to add, but that was a very bad example of poor judgment on this person's part.
Correct.
One thing one question I might ask, and it's something that we have updated on the website recently. Can you talk about what it means to be released? How it doesn't necessarily, it may not mean that you're not still sick, but what it means to be released.
No longer contagious. Dr. Lehman usually can answer that one the best.
There you go, you answered it. You're no longer, we deem that you're no longer contagious. And there are criteria, which I think Laura just mentioned, which is it's been at least 10 days since you've been sick, since the onset of your illness, and you have not had a fever for at least 24 hours, and your symptoms are improving. So if you have all those, then you are considered non-contagious and released from isolation.
And that's when from a public health perspective, that's when our concern stops. Not concern, but our, the thing that we watch. I mean, we watch people up until the point, or we follow them up until the point they're no longer contagious. That doesn't mean that they haven't gotten really ill from the disease and are still ill, may still even be in the hospital, may still pass away from some lingering complication from having had the disease, but they're no longer contagious. So they're no longer a threat of spreading it. And that's the public health concern, is more the control of the spread of a communicable disease part of it. So yes, we will release some people sometimes who are still sick or even hospitalized, and someone who's released can even pass away from a COVID-related complication, but they're not contagious. So that's the one. So the only other point I had on my list that we didn't talk about was, people will ask us now, they'll say, early on in the outbreak, there was all of this modeling that predicted these catastrophic consequences, and that hasn't played out by and large. So what are we still doing, being involved with this? To which I will say, I'm very thankful that the model, the catastrophic models hasn't turned out to be true. So that's great. So, it's easy to look back. We're at this moment in time, and we can say, well, we shouldn't have done, an economic shutdown or whatever at the national level or the state level. But that's using today's hindsight to look back. The thing we have to remember is back in March, when this was starting in Kentucky or a few weeks earlier in the United States, the information was very different back then. This was a virus that originated in China, and there was speculation it was engineered and intentionally released to the public. Whether you agree or believe with that or any of that, that was the speculation. The second thing that happened was that the second place that it impacted other than China was Italy. And in Italy, there was just a tremendous mortality rate attached to it. And why Italy stood out so much at that point in time compared to later circumstances, I'm not entirely sure. I just know that in the beginning, you had the fear that this was a bioengineered attack, and you had the fear that the mortality rate that showed up in Italy was going to show up everywhere else. So as this started spreading across the world leaders looking at those two pieces of information made the decisions to isolate or to have an economic shutdown or a lockdown or to restrict people. Now, fast forwarding, we know from reality that those catastrophic models haven't played out. So what is it we're trying to do at this point? What's our goal as a public health? Without a doubt, you can Google this on your own. You can Google and get a list of states that have the most restrictions versus the states with the least restrictions. And then you can look for maps on Google of states that's has the most current incidence, states that has the most hospitalizations, states that has the most mortality, states that's had the most cases historically. You can see any map you want. But as far as new cases go, the states with more restrictions have less cases, less mortality, less hospitalizations, and the states with the least restrictions have the most cases, the most hospitalizations, the most mortality. Kentucky's right in the middle of that. We're largely back open. There are still some restrictions. We still want people to mask and social distance. What are we trying to accomplish? Well, we we simply want to reduce the amount of mortality, the amount of death, and the amount of hospitalizations, because we believe a vaccination is going to happen soon, maybe this year, maybe next year. So if we can, if we've got some light at the end of the tunnel, and it's not that far away, then let's just see, without totally shutting down the local economy here, locking people down, can we social distance? Can we mask? Can we sanitize? Can we do the things we need to do to reduce the amount of hospitalizations and the amount of mortality between now and the vaccination? So, we're not in favor of totally locking everything down. We're not in favor of, saying it's safe to go out without a mask and be in large crowds. We're trying to take a middle ground and say, let's do what we can to use our common sense to try to keep the hospitalizations and mortality down, because the vaccine's not that far away. So that's what we're trying to do. Does anyone have any other things to add? There's no questions that's popped in on the chat. So
Dr. Wayman, here's just a thought that you might want to share with people. It is flu season, so you might want to do your little spiel for us.
Get your flu shot. You don't want to have both COVID and the flu.
yeah, COVID kind of started in the United States at the tail end of last year's flu season. And that could be the reason why it started out so much more powerfully, I don't know the right word, in the beginning, because it was much more chance of having both flu and COVID at the same time would have been. But anyway, we're getting ready to go back into flu season. You don't want to get both of these things at the same time. That would not be good. So get your flu shot.
True. Anybody else have anything else they want to share? No, and there are no questions in the box, Sean?
Nope.
All right. I want to say thank you all for joining us today, and we will be back next Wednesday at 2 o'clock. If you have questions, please share those, and we'd be glad to answer. Thank you all.
Thank you
Have a
all.
good day.
Thank you. Bye.